Welcome to the workshop, Women's Sexual Health After Transplant. My name is Sue Stewart, and I'll be your moderator for today's session. It's my great pleasure to introduce to you Dr. Jordan Rullo. Dr. Rullo is a board-certified clinical health psychologist and adjunct assistant professor in the Department of Clinical Psychology at the University of Utah. She also maintains a private practice in Salt Lake City, Utah. Her specialty includes sexual health concerns and sexual health related to menopause and cancer. Please join me in welcoming Dr. Rullo.
Thank you. Thank you for that nice introduction. Thank you all for being here. I'm very excited to be here and give this presentation. So my presentation today is on women's sexual health after transplant. So let's dive right in. A few learning objectives. We're going to talk about the incidence and type of sexual difficulties in women following hematopoietic stem cell transplants, the impact of these on quality of life, techniques and therapies available for improving quality of sexual experiences, and the cause of pain during sex after transplant and possible treatment strategies. Nearly half of people after stem cell transplant experience sexual dysfunction. And for women, this sexual dysfunction does not get better over time unless it's treated. And this is what we're going to be talking a lot about today. So let's talk about sexual health and transplant, the most common sexual health concerns: low sexual desire, sexual pain, reduction in quality and quantity of sex, and poor body image, as well as infertility. These are the most common sexual health concerns. And in today's presentation, I'm going to be focusing on these three, the top three: low sexual desire, sexual pain, and reduction in quality and quantity of sex. You are at greater risk of these sexual health concerns if you are or have been on chemo, if you've had total body irradiation, if you're on a variety of medications, and if you're experiencing just overall psychological or psychosocial distress. And what happens is there is this vicious cycle that develops, because with the treatments you're on, if your sexual function declines, then you feel bad. And then because you feel bad, your sexual function declines even more. And then your partner feels bad. And then that probably causes some sort of relationship discord that reduces just overall quality of life. If this is happening to you, you're probably wondering, okay, well, what do I do? Well, first of all, what I want to say is transplant does not take away your sexuality. It does not take away your sexuality. There is treatment for sexual health side effects after transplant. So the most common sexual side effects are low desire and sexual pain. And we're going to talk about both of those. We're going to talk about how to treat them, and then how to navigate your sexual relationship if you're dealing with these sexual side effects. So let's start with the first one, low sexual desire. And in order to start with this, I've got to describe a few important things around sexual desire. So super, super important. There are two types of sexual desire, and a lot of us don't know this. If we did get sex education, it probably wasn't talked about. But even if, so most of us probably don't know this. What we hear with sexual desire is probably what we see in the movies. And mostly what you see in the movies with sexual desire is what's called spontaneous sexual desire. And that's that type of desire where you have that internal drive, that internal craving, and just spontaneous. You're like, oh, I really want to have sex right now. That's the main desire we're probably seeing in the media that's talked about. We see in the movies as spontaneous sexual desire. But there's a second sexual desire that is equally important that we're going to spend a lot more time talking about, which is called receptive desire. You also hear me in the presentation talking about it as responsive desire or willingness desire. So it has a few different names, but right now we'll call it receptive desire. And receptive desire looks like this. It is not spontaneous. You are not thinking, oh, I really want to have sex right now. In fact, you're in a really neutral place. Sex is not on your mind. But the ingredients are in place that allow you to feel receptive to being sexual. And so maybe those ingredients are, you're having a good enough day that day. Physically, you feel well. There's privacy. You're not feeling stressed out. You're feeling close to your partner. And then your partner initiates and you think, oh, well, I wasn't thinking about sex. It's not on my mind, but yeah, I would be receptive. And then once the sexual activity gets started, once your body starts to feel sexual arousal, then you're like, oh yeah, you know what? I'm glad we're doing this. Why don't we do this more often? That's receptive desire. Okay, so two different types of sexual desire, spontaneous desire and receptive desire. And I want to show you receptive desire kind of pictorially. So this graph, which looks a little bit busier, this model is called the circular model of sexual response. And so let me explain this. This is the model or the kind of the pathway in which women respond sexually. So if your main desire is this responsive desire, you're going to respond like this. And you're like, this, what is this? This is a really complicated slide. So let me jump in. In the middle of the slide, you see that spontaneous sexual drive, that kind of green box right in the middle of the slide. If you happen to have spontaneous sexual desire, you're one of those people that just randomly has that desire, that's going to kickstart this cycle. And you see 3 arrows coming from that box. So one arrow points down to sexual arousal, one arrow points over to sexual stimuli. So if you just happen to have spontaneous sexual drive, maybe you just happen to feel aroused in that moment, and that kickstarts this cycle. Or maybe you just have spontaneous sexual drive and you just seek out some sort of sexual stimuli. You want to go turn on Bridgerton or read a steamy novel. So that may be one way that kind of kickstarts your sexual response. You just happen to feel that spontaneous sexual drive. Now, the other way that can kickstart this cycle is, again, that receptive desire. So you can see in the upper right corner, it says being receptive to. So perhaps you're not feeling any spontaneous drive, but you happen to be receptive. All those ingredients are in place that allow you to be receptive. So now if we follow this arrow down, so let's say we're in the upper right corner where it says seeking out and being receptive to, so in the upper right corner, let's follow that arrow down. So you're receptive and there's some sort of sexual stimuli. Maybe that's your partner initiating. So partner initiates, and then let's keep following that arrow. As long as biologically and psychologically everything's in check. Biologically, your body's feeling good. Psychologically, you're not too stressed. You don't feel depressed. Then let's keep following the arrow. The next thing that happens is sexual arousal. And let's keep following the arrow. And that arousal eventually leads to sexual desire. Now, I want to pause for a moment and really highlight what's happening here in the cycle. What this is saying is that for most women, if their main desire is that receptive desire, not that spontaneous, but that receptive desire, what has to happen first is arousal has to happen first. That means the body has to get aroused. The body has to feel sexually aroused. And then on the coattails of that arousal comes desire. So the body gets started, the body gets kickstarted, and then the mind says, oh yeah, this is nice. I kind of like this. I kind of want to do this. Why don't we do this more often? So the body gets started, and then the mind comes on the coattails of that. So then let's keep following that arrow up. That leads to some sort of emotional and physical satisfaction. Some people describe the satisfaction they get from a sexual experience as orgasm, but a lot of people don't. They find satisfaction in other ways, or they find emotional satisfaction. Again, keep following the arrow around. That leads to feeling emotionally intimate or emotionally close with the person you're being sexual with. And then keep following that arrow, and then that cycle repeats itself. If you feel emotionally close with your partner, then you seek out, or you may be receptive to, some sort of sexual stimuli in the future. And again, that cycle repeats itself. We will come back to this because this is really important. So remember this model. We'll come back to it. Now, if you are on any sort of medication or have had any sort of treatment that impacts your hormones, that is going to change your sexual desire. It's going to change that spontaneous desire. Now, spontaneous desire, you think about it having a gas tank. Most of the gas that fills that gas tank is hormones. And then the rest that fills that gas tank is that honeymoon phase of a relationship. So we know the first 12 to 36 months of a relationship is that honeymoon phase where your partner can burp and you think it's adorable. And that's often where a lot more sexual activity is happening. But again, that cannot last any more than 36 months. I don't think I've ever worked with a couple where they've been in that honeymoon phase for more than about 6 months to a year. So if you are on a medication that's impacting your hormones and you're in a relationship that's longer than 12 to 36 months, so you don't have that honeymoon gas anymore, what that leaves you with is your main desire is likely that receptive or responsive or willingness desire. Now, if this is you and you're saying, yeah, that's kind of what I'm left with. I don't have that spontaneous desire that I used to have before. I used to think about sex, a couple times a week, but now I don't. This is where you're at, so let's talk about next steps. What do you do with this? So to discuss what to do with this, I got to describe something that sounds really nerdy, but it's incredibly helpful, and it's called the dual control model. So the dual control model is based on the idea that for everybody, so for women in particular, but for everybody, their sexual function is based on divided into a brake pedal and a gas pedal. So in order for your sexual function to function, in order for you to have desire, you need to have more on your gas than on your brake. So for example, things that hit the brake pedal might be if you're not feeling good about your body image, if you're tired, if you've had chemo, maybe you're feeling depressed, anxious, or stressed, those all hit the brake pedal. Things that hit the gas pedal, your partner smells good, they look good, there's novelty in the relationship, maybe you have a strong emotional connection. So like I said before, you have to have more on your gas pedal than on your brake pedal in order to have a sexual desire. What's most important between these two pedals is actually the brake pedal. A lot of times when I see couples in my office, they say that when there's low desire, they've tried everything they can to put stuff on the gas pedal. Oh, we've tried date nights, and we've tried lingerie, and we brought in toys, but that's actually, at least at the beginning, not very helpful. And the reason is, if you really think about this brake pedal and gas pedal as, think about it as the brake pedal and gas pedal of a car. If there is so much on your brake pedal, so much weight on your brake pedal that your brake is pushed all the way to the ground, all the way to the floor, and then you decide you want to put your foot on the gas pedal, what's going to happen to your car? It's not going to go anywhere. I mean, maybe the engine's going to rev a little bit, maybe the tires might spin a little bit, but that car is stuck. If you have a ton of stuff on the brake pedal, then the gas pedal is pretty irrelevant. So the first line in treating and managing a sexual health concern and trying to improve your desire is figuring out what is on your brake pedal and then removing as much as possible off that brake pedal. And then once you've got some weight off that brake pedal, then you can start thinking about putting your foot on the gas. Then you can start thinking about adding things to the gas pedal. But when that brake is to the ground, the gas pedal is pretty useless. So what I'm going to go through is the main things with transplant, and in general as well, but the main things that hit the brake pedal. And I'm going to divide these things that hit the brake pedal into 4 areas. We call these 4 areas the biopsychosocial model, because there are biological or physiological factors that hit the brake pedal. There are psychological or emotional factors that hit the brake pedal. There are relationship factors and other social cultural factors, all that hit the brake pedal. So as I'm talking through this, if you fit the category of what I've been describing, you feel like your desire is low, you're more in that receptive category, maybe there are a lot of things hitting your brake pedal. As I'm talking through this, I really want you to think, oh, how do I fit into this? Is that hitting my brake pedal? Is that hitting my brake pedal? Really kind of have a running list, or even grab a piece of paper and jot down, yeah, what are the things hitting my brake pedal when it comes to my sexual function? Okay, so we're going to start with the physiological or biological factors that typically hit the brake pedal, especially with transplant. Total body irradiation absolutely is going to hit that brake pedal and how it impacts your body, your health, your hormones. Chemotherapy, again, same thing, how it impacts your body, your health, your hormones, fatigue, energy. Genitourinary syndrome of menopause, which we're going to talk more about toward the end of this presentation. I'll refer to it later as GSM. It used to be called vaginal atrophy, and it was when the vulva and vagina dries out, loses its elasticity, penetrative sex becomes painful, but they changed the name to GSM, or genitourinary syndrome of menopause, for one reason is women were tired of being told that their vagina had atrophied. So this is a much more accurate way to describe the system, because it's not just about the genitals, it's also about the urinary tract. So GSM, genitourinary syndrome of menopause, basically the vulva and vagina are in a state where any sort of penetration can be really painful. Aging, as you get older, when it comes to sexual function, everything just takes longer and is less intense. It takes longer to build arousal. There's less vaginal lubrication. It's more difficult to reach orgasm. Orgasm is less intense. Hormones, and like I mentioned before, anything that's going to impact hormones is going to impact that spontaneous sexual desire, and there are a lot of treatments when it comes to transplant that impact your hormones. And fatigue, I gotta keep mentioning this as well. Lots of treatments related to transplants that are gonna impact your energy level. And at the end of the day, if someone offers you a platter of sex versus a platter of sleep, and you're saying, oh, I will take the sleep platter any day, well, that says that fatigue is probably something hitting your brakes. Okay, so next category, psychological emotional factors that hit the brake pedal. Anxiety is a big one. What happens with anxiety is it really shuts down sexual function, because in order to have desire, or in order to get aroused, you need to be in a relaxed state. You need to feel safe and relaxed. But when you're anxious, you're scanning the environment for threats. So I imagine, let's say maybe you have your doctor's appointment every 6 months. Every 6 months you've got your appointment. And I'm sure a month before, weeks before, you are starting to get really anxious. You are worried about what the future holds. You're scanning the environments for threats. Probably a really difficult time to be sexual, because you're not in a place where you feel safe and you feel relaxed and calm. Depression. What depression does is it takes away motivation and makes it difficult to enjoy the things you typically enjoy, makes it difficult to be more connected with your bodily sensations, and so that really hits the brake pedal when it comes to sexual function. For body image, if you're not feeling sexy, it's hard to want to be sexual. History of sexual abuse or trauma. So if the sexual activity you're going to engage in triggers a history of sexual trauma that you've had, probably don't want to be sexual. Distraction. So oftentimes I'll ask, when I'm trying to really assess someone's level of desire, the desire in their mind, because there's a physiological arousal, vaginal lubrication, blood flow to genitals, but there's also the arousal in your mind. And so I'll ask, when you're actually being sexual, what is going through your mind? And oftentimes what I will hear is, oh, I'm thinking about the to-do list, or I can hear the kids in the other room, or I've got this deadline. So if your mind is distracted and you're thinking about everything else except for sex when you're being sexual, that is definitely going to hit that brake pedal. And then substance abuse. A little bit of alcohol can be helpful to kind of reduce inhibitions, but when it comes to more than that, then you're really reducing your ability to be aroused. Now, interpersonal relationship factors. Discord. If you're not happy in your relationship, probably don't want to be sexual with that person. If you're not feeling emotionally close to that person, probably don't want to be sexual with them. Think back at that slide that I showed you, that circular model. One of the main ingredients for that sexual response model to continue was emotional intimacy. So if there's no emotional intimacy, that's a huge break in that circular model. Partner dysfunction. What's interesting is research consistently shows that if your partner, if they themselves have their own sexual functioning issues, it is going to make it more difficult. It's really going to hit the brake pedal for you. Inadequate stimulation, so perhaps just the right buttons aren't being pushed, so the sexual experience isn't that enticing or exciting for you. And lack of privacy. I cannot tell you the number of times I have worked with people and I've asked them, hey, when you're being sexual, what's in your mind? And they'll say, I'm so worried about the kids coming in the bedroom. And then I'll say, oh, well, do you have a lock on the bedroom door? And the answer is, oh, no, we don't even have a bedroom door. What? If we think about the treatment plan being removing as many things off the brake pedal, then step one is go to Home Depot, go to Menards to get a door. And then last is sociocultural influences that hit the brake pedal. Limited sex education, conflict with religious, personal, or family values, societal taboos, all of these things can hit the brake pedal. So, I had said before to really think about these things that hit the brake pedal and think about, do any of these things hit the brake pedal for you? And if they do, what would be helpful is to kind of take a piece of paper and draw these 4 columns: biological, psychological, relationship, and life stuff. Life stuff kind of fits that whole sociocultural category. So take out this piece of paper, draw out these 4 columns, and then start to really fill out what are the things in each column that are hitting your brake pedal. So maybe some of you would say, well, biologically, yeah, I've had treatment-induced menopause because of the medications I'm on, so I'm having hot flashes and night sweats, and I'm tired, and I'm not happy with my body image, and I've been having more arguments with my partner, and I'm stressed out because I'm in that, sandwich generation where I'm taking care of kids and taking care of my parents. And so maybe this is what you're what your daily breaks are on your brake pedal. But whatever they are for you, really write them out and put them in the different categories, because the next step is to determine what can possibly be alleviated or removed. Again, we think about that dual control model, brake pedal, gas pedal. First step is what's on the brake pedal and what can possibly be removed off that brake pedal. Don't even think about gas until you've removed things off that brake pedal. So if you are left with receptive desire being your main desire, again, the next steps are what is hitting the brake pedal and what possibly can be removed or alleviated off that brake pedal. This is a really, really good book. It's called Come As You Are by Emily Nagoski. It is a great book that talks not only about the brake pedal, but also about the impact of all the pieces of the brakes that impact your overall sexual function. It talks about negative messages about sexual health. This is hands down the best book I have ever read on women's sexual health. And if you are really interested in this topic and improving your sexual function, I would recommend you reading this book. It's not transplant specific, but there's so much information in here that you will probably find very, very beneficial. Okay, so what's the take home on low desire? Because we've been talking all about low desire. Two types of desire, spontaneous or willingness. Again, it has a few different names, willingness, responsive, receptive. But there are two types of desires. With hormonal changes, that willingness or responsive desire may become your predominant desire, right? That spontaneous desire does not have really much, if any, gas in that gas tank anymore. So you're left with that willingness or responsive desire. And so really what you need to do is maximize your willingness to figure out what ingredients need to be in place for you to be willing. Okay, now we're going to shift to sexual pain, because that is the second most common concern after transplant. So sexual pain in transplant can be caused by a couple different things. Most commonly, it's caused by genital graft-versus-host-disease and treatment-induced menopause, which in turn causes GSM. Remember, I talked earlier about genitourinary syndrome of menopause. So these are the two things that we're going to talk about. Let's start with genital graft-versus-host-disease. Okay, a little bit of a quiz. And I know you all are on mute, so you can't answer this quiz, but try to answer it in your mind. From what percentage to what percentage? What's the range of percentage of women who have genital graft-versus-host-disease? You know, is it 5 to 10%? Is it 30 to 40%? So what it is 29 to 49%, depending on the research study that you look at. But nearly 50% of women have genital graft-versus-host-disease. And if you have non-genital GVHD, you are likely to have genital GVHD. Most women develop genital GVHD by 7 months, but 25% of women develop GVHD up to 9 years after transplant. And typically, genital GVHD is asymptomatic if you're not sexually active. So you may have kind of non-specific symptoms initially with just vaginal dryness. But then if you do become sexually active, you're going to experience sexual pain, discharge. You're going to experience decreased elasticity of the vaginal canal. So the vaginal canal should be like a rubber band. It should have the elasticity of a rubber band, but with GVHD, it loses that elasticity. There are adhesions and scarring of the vaginal canal. There can be vaginal stenosis, which is significant scarring. The second cause of sexual pain is treatment-induced menopause. And treatment-induced menopause can be caused by surgery, chemo, total body irradiation. And it's different. Induced menopause, treatment-induced menopause is different from natural menopause. It was the way it impacts women, because treatment-induced menopause has this sudden onset. So you begin treatment and then boom, your body just doesn't have those hormones before, like it had before. As a result of that sudden onset, the symptoms are much more severe, and the symptoms may not entirely respond to hormone treatment. So really the gold standard in treating treatment-induced menopause is estrogen. And estrogen not only helps the whole body, but it helps with sexual function. So estrogen really helps maintain the physiological function of the genitals. It is critical in preserving vaginal sensation, vaginal lubrication, preventing sexual pain, promoting sexual arousal. So the way I think of it is the vulva and vagina have tons of estrogen receptors. And when you undergo a treatment that impacts, changes, reduces your level of estrogen in your body, those estrogen receptors in your genitals they dry out. They're not being fed with estrogen. And then what happens is when those estrogen receptors dry out, everything gets dry, you lose that elasticity, you're not having that same lubrication, there's less blood flow to your genitals because those estrogen receptors actually help to promote blood flow to your genitals. And if you think about sexual function or sexual arousal is blood flow to the genitals. So if you're not getting that same level of blood flow, then that means arousal is going to be much more difficult. And if you don't have that same elasticity, if you don't have that same kind of moist, plump vulva, then that means penetrative sexual activity is going to be painful. So estrogen is incredibly helpful in getting that sexual function back to your genitals. Without estrogen, about half of women report that they experience genitourinary syndrome of menopause. Okay, so if you are having painful sex, what do? Step one, stop. And it may sound silly that I'm just saying stop, but it is incredibly important that you stop. I have worked with so many women that say, well, I just feel like either I have to because it's important to my partner, or, well, isn't it okay that sex just hurts a little bit, or, I can get over it. I can, use some ice or just take a break for a couple days afterward. No, stop. And I'll tell you why it's so important to stop. Because what happens is every time you have painful sex and pain start to get paired together. So when you even think about sex, or your partner comes up and touches you and hasn't even said sex, but just comes up and touches you or hugs you or holds you, your mind goes right to, this is going to go to sex and this is going to hurt. And then, so again, anytime you think of sex, you think pain. So over time, those two just get connected. When you think sex, you think pain, and then you start avoiding sex, and then you start avoiding your partner touching you. So if you continue to have painful sex, a really damaging dynamic is going to get created over time. So stop having painful sex if you're currently having it. The term for this in the research is called the avoidant dynamic. The avoidant dynamic is you are avoiding sex because you don't want pain, and then your partner is like, oh, okay, well, I don't want to initiate sex because I know it's painful for her, so I'm just not. So now both of you are not initiating any sort of sex. And then what happens is your partner, that non-sexual physical affection, touching, hugging, cuddling, that stops, because every time your partner goes and touches and hugs and cuddles you, you think, oh gosh, is my partner initiating sex? That's going to be painful. I don't want it. So now you start to pull away or flinch, and then your partner's like, well, every time I go up and touch her, she pulls away, she flinches, she's not touching me anymore. So I'm tired of being rejected. I'm not going to touch her anymore. So now that non-sexual physical connection, that starts to decline. And then there's this ripple effect to the emotional connection. And this is where over time, when there isn't sex, when there isn't that non-sexual physical connection, then that ripple effect goes to the emotional connection. And this is where couples come to me in therapy and they say, we feel like we're just roommates. So if you continue to have painful sex, that is taking you down the potential pathway of developing this avoidant dynamic. And the longer you ride that avoidant dynamic, the more likely it is that you two are going to end up in a place where you just feel like roommates. So stop having painful sex. Step two is really consider there are some over-the-counter options to address sexual pain. So moisturizers, I have a colleague that she calls moisturizers face cream for your vulva or vagina. Just like you wake up every morning and you probably put on some sort of face cream, that's what moisturizers are. There's something that you use every day or 3 times a week, and they are, so you rub them on the vulva and the vagina, and they help trap moisture to the vulva and vagina. And it is the cumulative effect of using them that is helpful. So you can't just use a moisturizer once. It's using them on a daily basis, making it a habit that traps in that moisture. So it just reduces that daily vaginal dryness. So using a moisturizer is really helpful as just kind of a daily maintenance to keep the vulva and vagina more plump and moist. Now, moisturizers are different than lubricants. Lubricants are as needed in the moment for friction reduction. They're not something that you use every single day or multiple times a week. It's just an in-the-moment accessory. There are water-based lubricants and there are silicone-based lubricants. Water-based lubricants are, most people like water-based lubricants. There's no contraindications to having a water-based lubricant. The only thing about a water-based lubricant is because its base is water, it can evaporate quickly, so you are often reapplying it during a sexual experience. Silicone-based lubricants last a lot longer because its base is silicone. So you probably do not have to reapply it. But the contraindication, a couple contraindications to a silicone lubricant. One, if you have a partner, if you have a male partner and that partner has any sort of erectile difficulties or just difficulty keeping his erection, then the silicone may be so slippery that it's hard for him to maintain his erection. And two, if you use any sort of sexual toy that is made of silicone, it's possible this silicone lube can counteract that silicone toy and ruin your toy. So those are two reasons you might think against using silicone. So water-based and silicone are good options though. So next, so you've got 1, stop having painful sex. 2, over-the-counter options to try to alleviate some of that pain. And also think about having a non-penetrative sexual menu. If what is mostly causing the pain is penetration, can you engage in other sexual activities unrelated to penetration? So create a new sexual menu. Consider non-penetrative sex. On my website, which I'll give you a link at the end of this talk, I do have a sexual menu you can download of all non-penetrative sexual activities. There's also a website called Mojo Upgrade. It's not exclusive to non-penetrative sexual activities, but it's a ton of different sexual activities that you and your partner can each log into the website and rate your willingness or interest to engage in different things. But consider creating a new sexual menu that doesn't rely on penetration if penetration is what's painful. Okay, so you've got step 1, you've got steps 2, and the final step is prescription options. Now, I'm not a physician, but I'll tell you typically what physicians do to treat these issues. For genital GVHD, a topical corticosteroid. You can also do prophylactic dilator use 2 times a week to try to avoid stenosis and adhesions. There are physical therapists called pelvic physical therapists. Their specialty is the muscles that impact the vulva, the vagina, the pelvic floor. And so you could work with a pelvic physical therapist who will help you get dilators that work for you, who will help you create a plan on how to do those dilators a couple times a week. And then, of course, routinely having a gynecological exam. Treatment of GSM, of genitourinary syndrome of menopause. Vaginal estrogen is that gold standard treatment. Again, if GSM is a result of those estrogen receptors drying out, well then how do you treat it? You feed those estrogen receptors with estrogen. It increases blood flow, lubrication, elasticity, increases genital tactile sensation. You feel more when you have that estrogen. And there are different ways to take it, a ring, a pill, a tablet. Those are all different options. I'm sorry, not a pill. I want to go back to that. A ring, a tablet, or a cream. A pill is a totally different way to take estrogen. If you take it as a pill, you take it systemically, it goes throughout your body. But these are, this is estrogen just to the vulva and vagina, just to that specific area of your body. So here's the take home on sexual pain. There are 2 main causes, genital GVHD and treatment-induced menopause, which causes GSM. Stop having painful sex. Use over-the-counter behavioral options. And prescription options if step 2 is not helpful enough. Talk to your doctor about prescription options. Okay, so lastly, I want to talk about the sexual relationship and the impact of these sexual side effects on the sexual relationship. Now, I already went through this circular model before. A couple of things to remind you about. For most women, their main desire is that receptive, responsive, willingness desire, not that spontaneous desire. Arousal has to come first in order to tap into that desire. Your body's got to get aroused, the right buttons have to get pushed, and then your mind says, oh yeah, this is nice. And if you look at the top of this circle, emotional intimacy, you got to feel close to your partner in order for this cycle to be able to continue. Now, this cycle, if you have a male partner, your male partner's cycle is going to look a lot different. And I'm going to show you the typical male cycle. So for men, this is called the linear model. It looks more like a roller coaster. So let me describe this. It starts with desire. So for most men, for about 2/3 of men, their sexual response starts with desire, meaning that they think, oh yeah, I really want to have sex right now, right? They have that spontaneous desire. I really want to have sex right now. That leads to arousal, which then leads to orgasm, and then leads to that resolution phase, which we could talk about as kind of cuddle time afterward. But the important thing I want you to take from here is for 2/3 of men, their sexual response starts with desire. I want to have sex, then arousal. And if we go back to the previous slide, For most women, for 2/3 of women, especially for women who have had transplants, their sexual response does not start with desire. It starts with arousal. Their body has to get started, and then their mind says, oh yeah, this is nice, we should do this more often. And oftentimes, if you're in a heterosexual relationship, if you have a male partner, your partner's not going to understand this. He's going to say, well, why don't you have spontaneous desire the way I have spontaneous desire? Because your sexual response is different. So oftentimes, just having this conversation and realizing that the way you each respond is different can be enough to go, oh, well, now we can try to figure this out. So your sexual response cycles may differ, and your partner may not understand that your desire is that willingness or receptive desire. Your desire is not going to look like your partner's desire. So talk with your partner about what ingredients need to be in place in order for you to be receptive, in order for you to be willing, right? What needs to be taken off that brake pedal for you. And remember that emotional intimacy is one of those key ingredients. Your cycle is going to kickstart with arousal. And if you have a male partner, more than likely your partner's cycle is going to kickstart with spontaneous desire, with just spontaneously having desire. Now, what if you're both in an avoidant sexual dynamic? I described that dynamic earlier. Well, here's how to avoid an avoidant dynamic. With these exercises called sensate focus exercises, and I'm a certified sex therapist, I teach these exercises quite often. And I'm going to give you the brief gist of these, but you can get a printout of the first 2 phases of these exercises, again, from my website. So sensate focus exercises, the basics of these are touching exercises. There is no sex involved. You set aside time for a private space, set aside 20 to 30 minutes for full body touching. You two are nude to whatever extent feels comfortable. No sex. You do have to agree that in order to do these exercises, you will not have sex. You do them every 48 to 72 hours, and there are phases, and each phase builds off the next phase. Now here's phase 1, and again, you can get this on my website. There is no touching of breast, chest, or genitals. So those traditionally more kind of erogenous or sexual zones are off limits. They're off limits in this first phase to really set these exercises up as just touching exercises, not sex. So again, no sex. You actually don't even talk during these exercises. You touch each other all over. And let's say you set aside a half an hour. For 15 minutes, your partner touches you, and then you say switch, and then for 15 minutes, you touch your partner. Use your hands and your fingers only. And while you're touching, you're focusing on sensations. That's why they're called sensate focus. Temperature, pressure, texture. Is this firm? Is this soft? Is this rough? Is this smooth? These sensations are always there. They are vivid sensations. They're reliable sensations. You're always going to have TPT when you and your partner are touching. What's great about these sensate focus exercises is if an avoidant dynamic has been created, this is a really nice kind of guided, protocolized way to say, you know what? I know we haven't been touching. I know we haven't been having sex. I just want to touch again. Can we follow these instructions and just do this a couple times a week just to touch again? It'd be really nice to touch and be touched. And since sex is off the table, all that pressure and worry that there might be pain, it's off the table. There's not going to be any pain. There's no pressure. You two just get to touch. So here's the take home on the sexual relationship. You and your partner's sexual response differs. Your sexual response may need sexual arousal as a kickstart. Emotional intimacy is a necessary ingredient, and if you're in an avoidant dynamic, really think about sensate focus as a way to get out of that avoidant dynamic. Now here's the overall take-home message of the entire presentation. Transplant does not take away your sexuality. So really maximize your willingness, your receptivity with the right ingredients, and share these ingredients with your partner. Remember, try to get things off that brake pedal. If you're having painful sex, stop. Try moisturizers, try lubricants, try creating a non-penetrative sexual menu with your partner, and then talk to your doctor if you have GVHD or GSM, because there are prescription treatment options. If you're in an avoidant dynamic, consider sensate focus. So if you go to my website, which is my name, jordanrullo.com, go to my blog, you'll see a blog post that was just posted today on this talk, and you'll be able to download not only a non-penetrative sexual menu, but also the first couple phases of the sensate focus exercises. Thank you so much, and I believe we're going to be moving into questions in a moment.
Thank you, Dr. Rullo. That was a wonderful presentation. I learned a lot from it, and I'm sure others did as well. We'll start the question and answer session now. And again, if you have a question, type it in the ask the question box, and we'll try to get to as many of these as we can. All right, the first question. Is it possible to have penetrative intercourse with vaginal GVHD? And if so, how is it achieved when the tissue is fragile and the vaginal canal narrower and there's pain? What can help a spouse who longs for penetrative sex when I have vaginal GVHD and pain?
Such a great question. Hopefully the presentation answered this, but I'll just highlight some of the things that I mentioned in the presentation. Is it possible to have penetrative intercourse? Yes, it is, and it is likely going to be painful. So what I mentioned before is ideally you're avoiding sex and pain, because again, over time, if every time you have sex there is pain, then you're just going to drive yourself into that avoidant dynamic with your partner. What I talk about with women when removing that sexual pain is just not a possibility. Maybe the treatment for the GVHD, like the topical corticosteroids or the treatment that your medical provider is offering, maybe that's not working as well as you want it to. What I'll say to my clients is, okay, as you're creating your sexual relationship with your partner, ideally create a non-penetrative sexual relationship, so there's not going to be that pain. And then can you two talk about sometimes pain? So sometimes, if penetration is incredibly important to both of you, can you kind of plan the environment of, okay, sometimes, once every couple months, you will have penetration, but you two talk through it. Maybe you know that next day you are going to be hurting, and so you are ready. You take the day off work. You have ice to be able to ice your vulva, and so you two really talk about it and plan for it if it is that important to you to have that act of penetration. But ideally, you're doing the medications, the prescription medications your providers offered. You're doing that prophylactic dilators that I talked about a little bit earlier, and kind of you're doing all you can to try to prevent any sort of pain with penetration. And you and your partner mostly have a non-penetrative sexual menu.
All right. Next question. Depression is present in this woman's family members, and she just had sertraline increased, and she knows that it tends to affect her sexual desire and arousal. She's wondering if there's an antidepressant that has less sexual side effects.
Yeah, that's a great question. Absolutely, there are a number of antidepressants that are known to have less sexual side effects. Sertraline is one of those that has higher sexual side effects. If you go to my website, again, it's my name, jordanrullo.com, and I have on my website a list of all of the articles I have published. You can download this article. There's an article on antidepressants and sexual side effects specifically for women. Download that article, and there is a chart in there that tells you which antidepressants have the least sexual side effects. But I'm glad you're bringing this up, because so many people don't realize that their medications could impact their sexual function, and their medical provider didn't tell them that that would be a side effect. So I'm glad you're recognizing that's a side effect, and you're right. There are other medications to be on that could have less sexual side effects. But check out my website and download that article on antidepressants and sexual function.
Great, thank you. All right, next question is from a 75-year-old woman who has no fear of getting pregnant. She wants to know, what protection do you need when you're taking, when you're taking Revlimid? She's interested in protection for both oral and intercourse.
Ooh, you know what, since I am not a medical doctor, I would not be the best person to ask that question. So I wish I had the answer, but I'm just not the right person to ask it, to answer it. So I'm sorry, I have to pass on that one.
Not a problem. All right, next question. Is a general gynecologist going to be knowledgeable enough about genital GVHD and GSM, or do I need to go to a specialized gynecologist?
Oh, that's such a great question. I wish the answer was that a general gynecologist would be knowledgeable enough about these issues, but sadly, the answer is most general gynecologists aren't. So I'm going to go back to, if I can move my slides back. Okay, so you see on the slide that says sex therapy referrals, the third bullet, International Society of the Study of Women's Health, ISHWISH. Their website, I believe, is ishwish.org, and you can find a provider. So ISHWISH is mostly comprised of medical providers versus therapists. ISHWISH would be a great website to go to find a provider. If someone is a member of ISHWISH, more than likely they know how to treat these more advanced genital sexual health issues. One of the things I want to say repeatedly is do not take no for an answer from a medical provider. So if you have your gynecologist or whichever medical provider, you say, look, I'm having sexual pain, or I need better treatment for GVHD, and they say like, oh, I don't know, I don't specialize in this, or I don't know much about it, then the follow-up needs to be, then please get me a referral. It is your medical provider's obligation to connect you with someone who can help you. So please get me a referral. Who can you refer me to? This is important to me. Don't take no for an answer. You know, as a sex therapist, I so commonly see clients, and it's especially women, who have repeatedly been dismissed and ignored by their medical providers when they have a genital vaginal sexual health issue. In fact, there's a research study that came out in the past 5 years or so that said that a woman with sexual pain sees, on average, 6 different medical providers before she gets an accurate diagnosis for her sexual pain. So unfortunately, you just need to be persistent and demand a referral, demand someone who does specialize in this or who they can refer you to, because a lot of providers just don't know. But yeah, that's such a good question, and I wish that was not my answer.
All right. Next question's a little lengthy. The woman says, I can't have vulvovaginal touch because of pain. I had both a stem cell transplant and breast cancer at the same time. I can't use vaginal estrogen, and I'm also on Arimidex, so I'm very, very atrophic. I want sexual intimacy, but I just can't even tolerate touch. What do I do?
Oh, first of all, I just want to say, oh my goodness, you have been through the ringer. So what I would say is really, if vulvovaginal touch is painful and there are kind of no options and you can't take vaginal estrogen, one thing I want to throw out there is to check with your oncologist just to be sure. And again, if they can't give you a good solid answer or they don't know the research, say please connect me with someone who does. But check with your oncologist just to be sure vaginal estrogen is not an option. Because what the research shows, and I can't stress enough, I'm not a physician, but my understanding of the research, estrogen just to the vulva vagina, not systemically, not throughout the whole body. Estrogen that is just to the genitals has very little uptake throughout the rest of the body. So even women who are told because of your breast cancer, because of your cancer, you can't be on hormones, if they speak to a specialist, the specialist says, no, actually it's okay if you just are on local estrogen, localized to the genitals. So I just want you to double check on that, because that really is the gold standard treatment to help reduce that pain for the vulva vagina. Now, let's say you've double checked on all of that, and for sure, estrogen is just not an option for you. Then it really is tapping into, I talked about those sensate focus exercises, full body touch. Your vulva and vagina are not the only erogenous, sensual, intimate parts of your body. So can you and your partner set aside time and just explore full body sensual touch? Perhaps there are other areas of your body where you can really get that intimacy and connection. Is it going to feel the same or as sexually arousing as the genitals? Probably not, but it will bring some of that intimacy back.
All right. Next question is, how do I know if GVHD is the cause of my problems?
Ooh, that again would be a medical doctor question. I mean, if we go back to, let me go back to the slide that talks about GVHD. Okay, so oftentimes asymptomatic, but some of the things you're going to notice, vaginal dryness, if you are having penetrative sexual activity, sexual pain, discharge. So really, if you're having vaginal dryness, if you're penetrative sex is something that you're engaging in and there's pain, if you're having discharge that is different than usual, all those are signs that something's going on. And so then it would be talking with your doctor to actually get it assessed. Is this general GVHD? Is this genitourinary syndrome of menopause? But if you have any of these symptoms, it is time to get it checked out.
Last question, I guess, because we're getting close to time. I feel an anxiety from catching germs and infections when being intimate and close to my husband. He's a teacher and he meets many people, and I feel that my brain has been conditioned to avoid infections in order to survive. I do catch infections and I just want to avoid them. What do you suggest?
So the first thing that pops in my mind hearing your question is, and let me make a comment and then I'll kind of pose a question. Oftentimes people feel anxiety about like, oh, I don't want to get sick or germs. But the question I have for you to think about is that anxiety high enough or significant enough that you really are avoiding physical connection? Is that fear of catching germs? Is that high enough that you are preventing yourself from doing things that otherwise, like, it would make sense for you to do those things? Yeah, there's a risk, but your mind is kind of inflating that risk. So yes, generally, here's my question. Is your mind inflating that risk? And if so, I absolutely would want you to work with a therapist to help manage some of that anxiety. Anxiety in many ways is helpful. Of course, if you're dealing with transplant, you do not want to be getting sick, so you need a level of anxiety to keep you safe, but is that anxiety much higher than it really needs to be? And that would be working with a therapist to really kind of assess that. And then the other thing I would just add is, if you haven't already had conversations with your partner, having conversations with him about, okay, I've got this fear, how can we find a way to be intimate where I'm feeling more safe and I'm feeling less likely that I am going to catch something or get something? Is he following guidelines or rules, or is he putting in place the ingredients that you need to feel safe?
I think we can squeeze in another question here. Someone has asked that you repeat where on your website they can find alternatives to penetrative sex.
Yes, great question. Okay, so go to my website, jordanrullo.com, go to the blog, and there's a blog post that I just posted this morning. When you go to the blog, you'll see the big logo for BMT InfoNet, and go to that blog, slide down to the end of the blog, and that's where it's going to say, hey, do you want a sexual menu? Do you want the sensate focus exercises? Just enter your email address, and then you get to download that PDF.
And if we can squeeze in one more, someone has just commented that there's a product for women who can't have penetrative sex due to adhesions or tightness. It's called ONUT, OHNUT, silicone rings that go on a penis and decrease penetration depth. Are you familiar with that?
Yes, ONUT is a great product. So imagine, I love the name ONUT because it's like 4 little donuts. So 4 little silicone donuts that all nest in each other to create one kind of big long sleeve or long donut. And for anyone who's having pain with deeper penetration, you have your partner wear 1, 2, 3, or all 4 of the donuts. And then it's like a bumper. So then the penis can't go in very far. And the thing about penises is that the most sensitive part of a penis is the head of a penis. So if the shaft of the penis is being kind of engulfed in those bumpers, and the only thing that's penetrating is just the head of the penis, that will still be really sexually stimulating for your partner because the head of the penis is getting the stimulation. So you're not getting that deep penetration, and he's still getting the head of the penis being stimulated.
All right.
And so ONUT is OHNUT, yeah.
Right. One other question, because I think this is not on a topic we already discussed. I underwent a transplant as a teen, was fairly recently in my 20s, and I was diagnosed with primary ovarian insufficiency. I'm devastated about the possibility of having difficulty getting pregnant, and I already feel like the dating pool is shallow for me because my hair never grew back and I barely date. I don't know when to bring up the fact that I'm wearing a wig. When dating someone, when do you bring up something like possible fertility issues?
So this is such a great question, and there is no right answer. You just got to think about what works for you. I work with so many people that they like date one. They want to get it out there. Hey, look, these are the things I'm dealing with. If you can handle these things, then I'm interested in going on a second date. But if you can't, then we're not going to work. There are some people that say, nope, I want to spend some time, create a relationship with this person, see if I even feel comfortable being vulnerable with them. And then a few months in, when I am feeling comfortable and we've developed a much stronger connection, then I want to tell them. There is no right or wrong answer. There's no best way to go about it. So it really just is kind of up to you on what you feel most comfortable with? I mean, you may not feel comfortable with either of those choices, but those are kind of the two main options. So what seems to fit best for you?
All right, I think we will do one last question, and that is, can dilators be picked out at a sex store with your partner, or do they need to be prescribed by a sexual health physician?
Ooh, great question. The easy answer to that is yes, you can get dilators over the counter, at a sex store, online. The deal is if you go to your local sex shop, they're probably not going to have a very good variety of dilators, and there are so many different types of dilators. There are silicone dilators, there are acrylic dilators. Acrylic is a lot harder plastic, and if your genital tissues are very thin and can rip and tear and are sensitive, you do not want that hard plastic acrylic dilator. You're going to want more a softer silicone dilator. The dilators I really like are Sole Source. So if you Google Sole Source dilators, those are a nice silicone set of dilators. So long story short, yes, you can pick them up in your local sex store, but they're probably not going to have a very good variety. I recommend you get a softer dilator, like a silicone dilator. And check your insurance, because insurance companies may reimburse you.
Do you want to spell Sole Source so we know exactly what you mean?
And I can even give you, I'm going to make sure I got the right website. One moment, I'm pulling it up. I believe it's just Soul, S-O-U-L, Source, but I don't want to tell you the wrong thing.
Okay.
Soul Source, S-O-U-L, S-O-U-R-C-E, soulsource.com.
Okay, great. Well, with that, we unfortunately are going to have to end the session. It's been very educational. Thank you so much. On behalf of BMT Infonet and our partners, I want to thank you, Dr. Rullo, for some very thought-provoking remarks. And I want to thank the audience for the excellent questions. They really were wonderful. If you have any other questions, please contact BMT Infonet. Please do download Dr. Rullo's slides, and we hope you enjoy the rest of your day.